I'll be talking about the use of the third hand for anterior segment surgeon for doing the surgery, the posterior segment help that you want to do with the. So let us just see as to how what we call as the third hand, as to how the posterior segment pars plana approach helps us.
23 gauge micro incision trocar cannula system forms the backbone of this instrument. Imperative to understand its component and usage to fully utilize the tricks shown in the subsequent videos. A typical non-valve trocar cannula set consists of three 23 gauge trocar cannulas, an infusion pipe, and 3 scleral plugs.
So this is the trocar cannula that you have, that we use, and this is how you fit it. You have to measure accordingly whether you're going in a phakic or a pseudophakic eye. These are self-retaining.
It's a relatively simple technique which can be mastered easily with little practice.
So let us see, when you are looking at these hypermature intumescent cataracts, doing a capsulorhexis, making a small rhexis and then spiraling it out would be there, but sometimes when the intralenticular pressure is so very high that you just make a small nick and you can just get a huge rip, and that is the Argentinian flag sign. And also you may end up in these cases who are associated with phacomorphic glaucoma with expulsive hemorrhage, etc. So this is a problem that you see in the hypermature cataracts. If you have this is a phacomorphic glaucoma. If you have access to the femto, you can get a good capsulotomy and you can get it out. But in this particular case, there was this patient who had phacomorphic glaucoma, high pressure, lot of comorbidities, and would not respond even to the medical therapy. So we had to take her up, this old lady, for cataract surgery. And in this particular case, we are using the third hand, as I call, and all that you have to do is when you put the cannula after the trocar, you put and you just remove the fluid that is there. You don't need to go in, because if you go in, then you could inadvertently, because it's a non-seeing area, you could damage the posterior capsule. So you can see here that the pressure is relieved. Once the pressure is relieved in this particular case, you can see that the capsulorhexis that we are doing goes on pretty well. You can see that it's a small rhexis that we are starting, and then you can spiral it out. And now you can see that the phaco procedure will also go on pretty well. So this hypotony that has been induced by removing this small amount of fluid is something that is helping us do this phaco procedure in a phacomorphic glaucoma, which we would have possibly had a very difficult thing. And then if we had opened it to do an ECC, then maybe or a SICS, there could be an expulsive hemorrhage. So you can see here that when we are going on to the IA, there is a pressure buildup, maybe some fluid misdirection. You can see that the globe has become hard again. So what do we do? You can, all that you have to do is that you just reopen, like the infusion is off at this particular moment, but you just take it out and just remove the excess fluid, and you can see that the eye again becomes soft. And there is absolutely no problem, and you can actually finish the irrigation aspiration and put the intraocular lens. This is just to do a peripheral iridotomy using the vitrectomy cutter, and we just apply one suture, remove this and apply one suture, and that is the end of it. Now, what I will wish to show again is a case where you are using the pars plana approach, where there is a traumatic cataract. You can see there is a big linear tear that is there, and we are trying to remove, and as you get the cortex out, you can see that there is a huge posterior capsular defect also. So if we continue with the anterior approach, there is going to be a problem. So you can use the vitrectomy cutter, go through the pars plana, and use it both either for aspiration or you can use it for the cutting mechanism. So both of them can be used, and then you can see we had already prepared for a posterior segment, and we are going in because we need to take in the vitrectomy cutter. And you can see here that this does not allow the increased hydration of the vitreous, and the vitreous would not come out. So this is what I'm trying to say, is that depending on the mode, foot switch position 2 is the vitrector, here foot switch position 3 is the vitrector. So you can move accordingly when you want to cut first or you want to suck first. So that is depending upon the what you are wanting to do, whether you just want to do a peeling as you are peeling here. You would not want the cutting action to be there. So this is actually a good way that you can do this, and then you can put a 3-piece intraocular lens. after you have cleared everything, and the support, we can get a support from the back on the intraocular lens, so that even in this particular case, because the haptic was going in, we were able to nudge it out. So this is a very controlled surgery that we have been able to do with the help of a posterior segment pars plana approach that we had in this particular case. So this is something that I wanted to show as another case. And now you can see this is a post-traumatic subluxated cataract that we have. In this particular case, you can see this is the iris going down, and you will see that we are doing, there is vitreous here that I wanted to show. And it is difficult to have a traction, counter traction, because of the vitreous and the subluxation that is there. So what we will use is the power of femto. You can see that the femto can cut through the vitreous also. And now we have again used the pars plana approach. We have prepared ourselves. You can see that we have put tricot, and the first thing that we do is to decompress the vitreous by removing the vitreous which is coming to the, you can see that this is a vitreous which is coming into the wound. Once we have removed the vitreous, you have a good capsulotomy which is there because of the femto. We had placed it in such a position that once the lens centers, the capsulotomy which will be pretty much centered, and then we are putting the endocapsular ring to cover this particular defect. Since it's a traumatic cataract, we don't expect this cataract to increase the subluxation to increase. And you can see that because of the previous nucleotomy that has been done, the epinuclear removal, the nucleus removal is pretty easy. We are using a bimanual approach to do the irrigation aspiration. And you do not allow the bag to be decompressed, and you put the viscoelastic, and then you put a 3-piece intraocular lens which is there, and you can then again go back and remove any vitreous that is coming there, and then you can actually see that there is a tag of the vitreous, and we will reverse it in the sense that we will use the side port here. After putting an infusion at the from the back, we will just take the cutter from the side port, and we will remove this vitreous, so that the iris which was getting peaked because of the vitreous which was there is taken care of, and you can see that we get a good round pupil at the end of the surgery. So this is the last part, which is the principle, where again we are using a pars plana approach for a chandelier's elimination. I think Shreyas is going to talk about it. So it's a self-retaining system, provides good visualization and leaves the wound self-sealing. So you can see here, this is the difference. This is the huge corneal opacity that you can see. We are putting trypan blue so that we can see how the corneal opacity comes into play. And then with the chandelier's endo-illuminator, I'll just show you once the microscope is off and only the chandelier's endo-illuminator is on, you can see that this is where it looks as if the corneal opacity has just disappeared. And you can go ahead, you get a very good 3D kind of an image which is there. Depth perception is fantastic. And you can see that this is where you are able to see the cracking of the nucleus, etc. Everything is so perfect as if the corneal opacity never existed. This is the epinuclear plate that is being taken out. This is the case which we can see where the lens is being put. This is a case with multiple blast injuries, and you can see that the lens, you can easily put it in the bag. So chandelier's endo-illuminator is a fantastic device by which you can actually take care of the cases. This again would require a PK, since there is a ban on doing a PK for foreign patients. This patient came in from, I think, Afghanistan or Iran. So we can, with the chandelier's endo-illuminator, we can go ahead, and the patient was one-eyed, and we got a good vision. And this is just to see whether the graft is sticking well or not in case of doing a DSEC. So you can see that we get very good results with the use of the pars plana approach for various different types of surgeries that we have for the cataract surgeon. So thank you very much for your kind attention. Thank you.